Okay, we'll start today. So those who are listening online, those who are viewing, this is the second session of solving an ABG, how to read an ABG. The first part was how to read an ABG. Means if somebody comes to you with an ABG report and you solve it and say, though this is having high anion gap, metabolic acidosis, HAGMA or NAGMA, normal anion gap, low anion gap, or respiratory acidosis, acute or chronic respiratory, whatever the cause. So you have solved the ABG that this peculiar disorder is present in this particular patient. Now today's session is how to interpret that ABG in clinical relation to patient scenario. If HAGMA is occurring in a particular patient, what could be the causes my patient is suffering from, and how can I change the management plan? So today's session is how to interpret the ABG in relation to clinical scenario. So those who are listening, don't worry, I am not going to write much on the board. Just listen to the conversation, listen to the discussion which we are doing. So yesterday we revised. The first step was solving a blood gas was to see the PO2 first. What is the oxygen status? Okay. Oxygen status along with alveolar arterial gradient, you need to differentiate whether a patient is suffering from hypoxemia, mild, moderate, severe, whether this hypoxemia is due to lung involvement or not lung involvement, whether it is a central cause or any other cause outside the lung. Secondly, what is the cost of breathing, patient is tachypneic or not tachypneic, and after that you were calculating the PCO2 level after the PO2 or PCO2. So we will discuss the PO2 and PCO2 in combination at the last part of this session. First we will start with acid base imbalance, okay, pH. So first we will start with metabolic part, metabolic acidosis. So in metabolic acidosis, how we have divided different disorders: high anion gap metabolic acidosis, normal anion gap metabolic acidosis, low or negative anion gap metabolic acidosis. Why this is anion gap? I have told you there is actually no anion gap in the human body. It's because our labs can't measure all the anions. They can measure positive anions more than negative anions. So some amount of unmeasured anions exist in the body, means some amount of anions, negative charge particles, lab cannot measure. So that unmeasured part is called as anion gap. So whenever this gap is increasing, we call it a high anion gap metabolic acidosis. In high anion gap metabolic acidosis, some extra anion has come from outside into the body, whether patient has ingested due to some poison, due to drug toxicity, metformin or any other poisoning, or there is some production of some certain anion which was not there previously in the blood. So if you go by list in books, long list is given, okay? But in clinical scenario, in ICU scenario, we will discuss the important point which we encounter in 99%, 95% of the time, in the patient which we are seeing in the ICU. So first, most common cause of high anion gap metabolic acidosis is lactic acidosis. Lactic acidosis means lactates have increased in your blood. Okay? Normal lactate levels remains in the blood for about less than 2 millimoles, and lactate is a very sensitive matter. When it increases, it is a marker of tissue perfusion. So lactic acidosis are three types: type A, type B and type C. Some don't consider type C, but type A and type B. Most common cause of type A lactic acidosis is hypoperfusion or hypoxia to tissues. In any condition when there is anaerobic respiration or in the cells, lactate will produce more and it will call lactic acidosis. So first and foremost cause in your blood gas, if the patient is having high anion gap and if your ABG shows lactate also, you are seeing lactate also rising, patient is having high anion gap, and you should correlate what is the cause. First cause you should come in the mind, tissue hypoperfusion. So tissue hypoperfusion, usually these patients are in shock or impending shock. Their blood pressures are low or they are on certain vasopressor supports which is inadequate to perfuse the cells. You can measure this on a daily basis. Suppose you have done a blood gas in the morning, you have done a blood gas in the evening, and your lactates level have started coming down in the evening. That is a good marker that patient is improving. Those supports remain the same, but at that support the tissue perfusion has increased now. Type B lactic acidosis. Type B lactic acidosis is not related to tissue hypoperfusion hypoxia, but is due to certain toxins which are being produced. There are many causes, but most common cause among these alcoholism. You have a cirrhotic patient in which the lactates are not getting metabolized in the liver. Okay? So it could cause hyperlactemia. Then you mitochondrial dysfunction can cause mitochondrial disorders can cause type B lactic acidosis. Malignancy, at times diabetic mellitus can cause type B lactic acidosis. There is one more form of lactic acidosis which is called Dielectric acidosis. In the bowel, the bacteria produce a lactate which is a D isomer. Routinely, which your ABG is measuring is L isomer of lactate. So if you are having unexplained acidosis in your ABG, which is high anion gap, and your lactate levels are normal, still you are suspecting some, you should also consider you should always consider Dielectric acidosis in such patient if there is a mesenteric ischemia. Got it? If patient is having mesenteric ischemia or certain abdominal pathology, then Dielectric acidosis is produced, which is not picked by your blood gas. You have to see Dielectric acid level in the serum, then you can pick out. So most common cause of high anion gap metabolic acidosis is lactic acid. Second most common cause is ketoacidosis. So different types of ketones are produced in the body. Three main resources. One is diabetic. In diabetic ketoacidosis, you will have ketones raised due to deficiency of insulin. Your patient is not able to metabolize glucose, and therefore the other components, fats and lipid, etc. are being converted into ketones. So ketoacidosis. So decay is one of the most common cause. If your urine, you will check the urine ketones. May or may not times urine ketones can be positive because of the dipstick. Because there is also a catch. It measures beta hydroxybutyric acid, and the ketones is acetic acid. So the strip which is ketones should be at a certain level, only then they will be picked in your urine dipstick test. So if you are you see a patient which is having high blood sugar, do a blood gas, and there is a acidosis and bicarbs are low, and there is a high anion gap, but still the urine ketones are showing negative, don't worry about it. Patient may be having diabetic ketoacidosis, just the dipstick which is not picking up. If the ketones are large, it will start picking up. Second most common cause of ketoacidosis is alcoholic ketoacidosis. We see cirrhotic patients and then, so second most common cause is alcoholic ketoacidosis. Third, starvation ketoacidosis. Patient has not taken food for a long time. Some CA esophagus patients come, or some oral CA patient comes whose nutrition is in pain, cachexic, and then there is no carbohydrate in the body. Then your lipids and proteins get metabolized and ketones are produced. Then it's a starvation ketoacidosis. You should always check phosphorus in such patient, like the way we tested in this lady, where phosphorus come very low, 0.8. So we always in starvation ketoacidosis check for phosphorus so that you don't miss out refeeding syndrome. We'll discuss refeeding syndrome in coming up sessions. In refeeding syndrome, what happens? There is deficiency of phosphorus, and there is a nutritional deficiencies occurs because there is deficiency of phosphorus, there is deficiency of sodium, potassium, magnesium. Sodium is not so low, but potassium, magnesium, calcium deficiency, there will be hypomagnesemia, hypocalcemia, hypokalemia. As soon as you feed these patients, because phosphorus is required for ATP production in the mitochondria, so that metabolism is impaired because they don't have a phosphorus. As soon as you feed the patient, the phosphate comes in the body, and suddenly all these anions which are there, they start getting metabolized. Already there is a shortage in the blood, and as soon as the phosphate comes, they start getting consumed in the energy production. So the blood levels of all these electrolytes goes down very fast, and this can cause cardiac arrest. Clear? So refeeding syndrome should always be kept in mind. So in starvation ketoacidosis, you should always check phosphorus and feed them slowly, gradually. Supplement phosphorus and then supplement all anions and then support. Then third most common cause we see of high anion metabolic acidosis is toxins or poisoning. Poisoning or drugs. metformin toxicity or some injection salicylate toxicity, patients have taken some poisoning material. So you should always consider in a patient who doesn't seem to be in any ketoacidosis, or patient is not having in shock, liver functions are okay, and some means gray zone in the history, you should always consider some poison injection is there. Okay? So these are the few major causes of high anion gap metabolic acidosis. Now coming to normal anion gap metabolic acidosis. In normal anion gap, what I have told you, there is no extra anion in the body which has come from. It's only the balance between chloride and bicarb which is getting deranged. Either bicarb we are not able to conserve, so it is getting loosed in the kidneys or the bowel, or we have pour extra saline, means chloride, into the body. So what could be the cause? Only three causes are there. Either iatrogenic hyperchloremia, means we have given lots and lots of sodium chloride in the fluid. So you have that's why it is also called hyperchloremic metabolic acidosis. Normal anion gap is also called hyperchloremic metabolic acidosis. So this is one of the most common cause when we give lots and lots fluid for resuscitation of the patient. But don't worry about it, it's never too much serious. The bicarb rarely drops below 15, even if the nagma develops. Second, most common cause is loss of bicarb. This occur either to the kidney or to the bowel. So if you have a patient who is losing bicarb through bowel, diarrhea, patient may have diarrhea, it will lose lots and lots amount, secretory diarrhea specifically, lots and amounts of bicarb in the, then you can have fistula, drains present near the bowel through which extra fluid is going down. But usually these drains loss of fluid in this patient is such that the bicarb loss is compensated. So they present with metabolic alkalosis at times because the patient is dehydrated, hypokalemic, so metabolic acidosis develop. But this GI loss can also present with normal anion gap metabolic acidosis. Second most common cause is urine, means kidneys. Kidneys are the culprit. So how will you differentiate between whether the GI is the cause or the renal is the cause? One is history. Second is, in normal anion gap, you should calculate urinary anion gap. So urinary anion gap is sodium minus potassium plus chloride. If urine anion gap is negative, that means kidneys are not the culprit. It is somewhere else, either in the bowel or you have given lots of fluid, that is the cause. If urine anion gap is positive, that means kidney are the culprit, something happened. So most common cause in renal is renal tubular acidosis type 1, type 2 and type 4. How will you differentiate? It's a very easy thing which have been taught by my teachers. So if your pH is more than 6.5, you have a normal anion gap acidosis, you have a negative urinary anion gap, and now if you see the urine pH, if it is more than 6.5, it is type 1 RTA. If urine anion gap is negative and your urine pH is less than 6.5, then look for the potassium. If it is hyperkalemia, then renal tubular acidosis type 4, and if it is normal or low potassium, then RTA type 1, RTA type 2. Clear? And most common cause of renal tubular acidosis type 4 in adult patient is diabetes. Okay? So this completes your normal anion gap metabolic acidosis. Now a little word about low or negative anion gap metabolic acidosis. Understand this. We have measured your positive ions and negative ions. We always know that positive ions are measured more as compared to negative ions. Correct? So this is the gap, anion gap. Now any condition in which what we are measuring in the normal anion, what we are measuring, the major positive ion which we are measuring is sodium at times potassium. These are the ions which we are measuring. Here we are measuring chloride and bicarb, other we are not able to measure. Now this is the amount of anions which can remain in the body. Now any condition in which the anion which we are not measuring, positive anion, increases in your blood, so the level of sodium will come down, the quantity of sodium or potassium will be low, and this space will be occupied by magnesium, calcium, potassium, other positive charge particle which we are not measuring, which we are not able to measure. So you are listening, this has your positive negative charge ions, This was your positive charge ions. Now the measured positive charge ions are low because the unmeasured positive charge ions has increased. So the anion gap may be low or become negative. So what could be causes of what could be these unmeasured positive ions? They could be lithium toxicity, patient on psychiatric patient on medication, bromide toxicity, then you can hypercalcemia, hyperkalemia, hypermagnesemia, multiple myeloma, and hypoalbuminemia is one of the most common cause of negative anion gap. Due to low albumin, multiple myeloma and hypoalbuminemia should always be considered in the lower negative anion gap metabolic acidosis. Got my point? Why when these anions are increasing you are getting low anion gap? Because all these are unmeasured positive charge particles which you are not able to measure. That's why the measured anions quantity decreases, so you get a low or negative anion. Clear thing. So this completes your high anion gap metabolic acidosis. Now this completes your metabolic acidosis part. Now we'll see metabolic alkalosis. So I have told you metabolic alkalosis, there are only two causes which you should consider in your ICU scenario. Others are very rare. If your chloride, once your metabolic alkalosis is diagnosed, you do a urine chloride. Being condition is the patient should not be on any diuretics, otherwise the levels will alter. So first common cause is contraction alkalosis. Patient is dehydrated. Metabolic alkalosis. Patient requires fluid. Either patient is clinically dehydrated or intravascularly dehydrated. Patient may be severe hyperproteinemic. There may be fluid inside the body everywhere in the third space, but in intravascular compartment he is dehydrated. Or the patient is hypokalemic. These are, so in hypokalemic it is not fluid responsive. You have to supplement potassium, only then your metabolic alkalosis will get corrected. Any more causes you know? Anything more coming in the mind? RT aspirate, vomitings. You are losing fluid from here also. This can also cause metabolic alkalosis. It will cause metabolic alkalosis with hypokalemia. You will lose potassium also. Laxatives at times can also cause, or at times the patient is on diuretics. Contraction alkalosis, cardiac patients on diuretics, losing lots of amount of fluid and potassium both. Hai? So you can get metabolic alkalosis. Now after coming to this, we come to a very interesting part which we told in the start of the class. Then we will discuss PO2 and PCO2 in relation to disorder. So as we have seen, in respiratory acidosis or alkalosis there is always acute component and chronic component. So there could be acute conditions and there can be chronic conditions. Now in acute and chronic both, there can be scenario when their lungs are normal and their lungs can be abnormal. Okay, so we'll discuss one by one. Okay, I have prepared the list for you people to make it interesting. So first we'll discuss respiratory acidosis. Means your PCO2 is rising, patient is hypoventilating, and there is carbon dioxide diffusion is not proper. So acute conditions of PCO2 retention in which lungs are normal. What could be the condition? Patient is hypoventilating, acute condition, but lungs are normal. So there could be central cause. Patient is not taking breath properly, head injury, seizure, trauma, encephalitis. Patient has given sedation, narcotics, poisoning. You can pick out. So acute condition, PCO2 rising and lungs normal. Now same acute condition, PCO2 rising but lungs are abnormal. Asthma, acute exacerbation of asthma or at times pneumonia. This can cause PCO2 retention. Now we come to chronic one. In chronic one, chronic respiratory acidosis in which lungs are normal. When chronically patient tends to retain PCO2 in which lungs are normal. Myasthenia, yes, myasthenia can present. Guillain-Barré, pump failure. Then you can have OSA also, obstructive sleep apnea. Lungs are normal, a patient tends to hypoventilate. motor neuron diseases, these diseases can cause. Now, very easy. Respiratory acidosis, chronic condition in lungs are abnormal. COPD, chronic obstructive lung disease. Got my point? How on ABG you can find out what is happening with the patient. Now, respiratory alkylosis, patient is persistently hyperventilating. Patient is persistently hyperventilating, but it can be acute, it can be chronic. Then again, normal lung, abnormal lung. So, acute condition, kaun se? Acute respiratory alkylosis in which lungs are normal. Anxiety neurosis, hyperventilation syndrome, fever, stroke, this type of condition, hyperventilating due to fever, acute condition. Now, lungs are abnormal, patient is hyperventilating, acute condition. Acute condition, lungs abnormal, patient abnormal means a tachypnic patient in which there is pathology in the lung, pulmonary edema, pneumonia, sepsis, all these most common cause. Pulmonary embolism can also come in that. Clear? Easy. Acute condition, respiratory alkylosis, patient is tachypnic and lungs are abnormal, cardiac failure, pneumonia, pulmonary embolism, sepsis, all this comes into this. Now, chronic condition of respiratory, patient is chronically hyperventilating with lungs normal. I have told you yesterday. Third trimester of pregnancy.
Yes, sir.
Hepatic failure, severe ascites, and hyperthyroidism. Now, respiratory alkylosis, chronic one, and lungs are abnormal. Patient is hyperventilating, chronically hyperventilating. So, either can be unresolved pneumonia or there can be associated pulmonary embolism, and it can be in liver failure patients there is chest infection develops and patient is hyperventilating. So, this way you can differentiate what is happening with the patient. So, yesterday class we have discussed how to solve an ABG. Today we have discussed one of the most common causes of different types of metabolic and respiratory disorders. In coming sessions, what we will do, we will pick different cases. We'll take the ABGs and we'll solve it live and we'll compare it with the patient clinical scenario. So this way you people will have understanding how ABG can be so useful. Okay? I think we'll stop here.